Right. Hello, everyone, and welcome. My name is Ines Abuali, and I'm your moderator for tonight's event. I'm a hematologist and oncologist at Mass General Brigham Cancer Institute in Boston. And I also have the privilege of being a Capello Fellow for Doctors for America this year. And I am so excited to welcome you all to our April Advocacy Grand Rounds event. Happy spring. Before we get started, I wanted to take a quick minute to invite you to officially join us at Doctors for America in our mission to improve healthcare for all. We are a movement of over 40,000 doctors and medical students across the country who have come together since 2009 to ensure that everyone has access to equitable, affordable, high-quality healthcare. Becoming a DFA member is very easy. Just use the link that we will place in the chat to support DFA's work to improve healthcare with incredible programs like this Advocacy Grand Round series. Tonight, we are live streaming this presentation on Facebook Live, and a recording will also be available, and all the materials will be available after our talk. A few quick ground rules for our educational session. We welcome and encourage your questions. It always makes for a wonderful discussion. Please feel free to use the Q&A feature in the chat, and we will address your questions during the second half of this webinar. And now on to our speaker. I am so thrilled and so excited to welcome Dr. Marta Wozinska. Dr. Wozinska is a senior fellow at the Brookings Center on Health Policy and is a healthcare economist specializing in prescription drugs and pharmaceutical supply chains. She has held senior economic leadership roles at the FDA, FTC, and HHS OIG. And if you need to look those acronyms up, I had to look a couple up myself. And she has advised the U.S. Senate Finance Committee on drug pricing. Her experience has also included academic positions at Duke University and Harvard Business School, and she serves as an expert witness in pharmaceutical antitrust cases. Dr. Wozinska earned her PhD in economics from the University of California at Berkeley, and a lot of the published research work she has done has really helped me personally in learning and understanding more about the issue of drug shortages. So thank you so much for being with us today. So excited for this opportunity to chat with you, Marta.
Well, thank you so much, Ines, for the invitation, and I look forward to our conversation.
Wonderful. I mean, I'm going to start out by saying that as a clinician, as an oncologist, I witness firsthand how disruptive drug shortages continue to significantly impact just my day-to-day workflow. So over the past few years, just off the top of my head, we've experienced shortages in IV fluids. We've experienced shortages in IV opioids that are used for treatment of cancer-related pain, have noticed shortages in many chemotherapy drugs that I use for my basic chemotherapy regimens. And from my practitioner's perspective, I can never really predict when will the shortage happen, why it happened, how it happened. And it always seems like we're scrambling at the back end of things rather than being proactive about anticipating and preventing it. So I'm hoping that today can shed some light on things. Before we dive into this conversation, I would love to just have you talk to our audience a little bit more about how you, as an economist, came to specialize in this field, studied drug shortages, and how did you get motivated to work in this area?
Well, thanks so much for this, and I will come back to the list that you provided because there are sort of two really interesting things about the list that you put forward that are going to be really important for our conversation. So, and when I've been involved in this topic for on and off for 15 years. I was working at the FDA in 2011 when we had really a dramatic number of shortages. In 2011, right now, shortages have been hovering over the last few years around 100 different drugs, which is really astoundingly large if you really think about this. But it was 240 some that year. It really was. I think there were 24 different cancer drugs that were in shortage. And uh, I was I headed the office of an office to sort of doing economic analysis at the FDA. And the center director approached me because she was asked to write an explainer about why shortages happen. And I started to really ask a lot of questions of a lot of different folks. And what came out of this is really sort of a combination of um, kind of the complexity of manufacturing coupled with economics. And there's a really substantial, significant economic driver that really underpins all of these shortages. So what's interesting in the list that you mentioned, carboplatin and cisplatin, major shortage. Saline, another major shortage. All these IV, fentanyl, morphine, hydromorphone have been in shortage, right? There've been a lot of drugs that are used for, crash cart drugs have been in shortage. I think at some point I was looking at the numbers, and something like 70% of those drugs were listed from among crash cart drugs. They're all injectables, right? If you really think about what kinds of other drugs have been in shortage, yes, we had amoxicillin when, sort of post-COVID, that was a big one. We've had ADHD drugs, but other than that, you don't really hear about solid oral dose drugs, tablets being in shortage, right? So it's more of an exception. And also they're generic. Again, I would say GLP-1s were really an unusual thing. It's usually a sterile generic drug. And going back to the economics and the technological drivers of this, there's a good reason why this happens. So, on the one hand, when you're making sterile injectables, the room for error in manufacturing is very, very small. When you take a tablet and there are impurities, there are some problems with this, your body can deal with this, right? They don't need to be sterile, right? But if it's a sterile injectable, it really, it's not acceptable. Like the room for deviations is very, very minimal. And because of this, they're much more complex to manufacture, and also a lot more things can go wrong. And so that's sort of one piece of it. Another piece of it is that we have a system that was set up, through Hatch-Waxman for what a generic drug is, right? And basically, the idea is that once a drug is approved as a generic, it's therapeutically equivalent to another generic and to the brand, which really means that it shouldn't matter which one you take. But what does this do? It sets up, on purpose, very strong price competition. Really, the only thing that matters is price. And so what you have is what I would say the race to the bottom. Buy the cheapest. Buy the cheapest, buy the cheapest, buy the cheapest. And in reality, and this is in reality, there are other things that matter, right? Reliability of supply is something that, the fact that you want that drug to be there when you want it to be there, that's somehow not incorporated into which drug to buy. They just go for the cheapest. That's really the kind of the overwhelming one. And so you put these two together, generics have very small margins, and then the sterile injectables are much harder to make. And it's sort of a recipe for disaster. And again, because a lot of it has to do with sort of, economic forces and the competition and incentives for buyers and so on, that's just like a perfect soup for an economist.
So essentially, I think we always lament as physicians how the system is broken, but it doesn't sound like it's broken. It sounds like it was designed on purpose to behave that way and to create this race to the bottom.
I would call it an unintended consequence. I think when we were designing the system, we made a lot of assumptions. And one of the assumptions is that, FDA could hold a line on quality, right? And they really struggle with that. You mentioned chemo drugs, carboplatin and cisplatin. post COVID, during COVID, FDA wasn't inspecting facilities. Post COVID, they went to this facility, Intas facility in India. And what they found was just truly astounding. It's not that they found dirty, systems. It was a relatively new company from what I understand, but it just seemed like there was fraud all over the place. They seemed to have had some heads up about inspectors coming, and they were basically had piles of papers on trucks, loading them off, like to ship off out of the facility. They even were pouring, like, because the inspectors were about to show up, somebody kind of got found out about this, and they were pouring acid on documents on site. So you look at all of this, and FDA is like, you know you can't ship any of this product, we can't trust it. And then the facility had to sort of prove that, triple test that the products were safe. And anyway, it caused quite a havoc. And so again, that's sort of one assumption that we have had. Another assumption we sort of followed is, I don't know if it was an assumption, but this therapeutic equivalence was then translated by payers to drive price competition, again under the assumption that FDA can sort of take care of it and product will be fine. And if you think about how hospitals are paid for generic drugs, for sterile injectables, there's two ways. If it's separately reimbursable, it's going to be ASP plus 6%, whatever it's 4.5% or whatever it is now. And what that means is that if there are 3 generic versions, you still get paid average sales price for all of these drugs. And so you have an incentive to buy the cheapest, because it doesn't matter which one you buy, you still get the same reimbursement, right? So this gives you an incentive to buy the cheapest. That drives the average sale price down. Great, we have competition. If you are on the inpatient side, you're going to have DRGs. There, you're not even getting reimbursed for the drug at all. It's just pure expense. Again, what kind of an incentive does a hospital have? To buy the cheapest, right? So payers very much reinforce that idea. But then you ask yourself, if you're a hospital, clinicians don't like shortages, patients don't like shortages. I mean, shouldn't a hospital want to buy, pay more? And sort of what's interesting, or what I've frequently tried to point out to folks, is that yes, hospitals do care about shortages to some extent, but they're not willing to pay as much to prevent them as it's really worth to patients. And I'll give you an example. Several years ago, Vizient, one of the GPOs, did a study looking at how much it costs hospitals to deal with shortages. And this is by hiring more people, spending more on drugs and whatnot. It came out to something like $360 million, which sounds like a big number, right? I think now it's actually maybe even double. But if you look at it per hospital per year, it's $60,000. That is, I'm sorry, but that's peanuts. That's nothing. On the flip side, there's this really well done paper that looked at the norepinephrine shortage back maybe 10 years ago or so. And during that shortage, if I am remembering correctly, what it was used for, so please correct me here, and what drug it was, but I believe it's a drug that's used for septic shock, right? For patients with septic shock. And the drug was not available, so patients were substituted to something else that's not as effective. And so there were a number of excess deaths. So, and the paper documented how many excess deaths. A researcher from the FDA actually took that number of excess deaths and simply applied the value of statistical life that the government uses for how much a life is worth. And when you did that for just that one shortage, for that one drug, it turned out to be $13.7 billion. And so you can see just this massive, massive discrepancy of what economists would call social value versus private value. So, you know, I if I were sort of were to place blame of why we have shortages, clearly some of it is how regulators set this up. But you could imagine that, that there are parties through the supply chain that would internalize it. And you would think that hospitals would be the first place to internalize it, but they don't. So there's a lot of noise about it. They would like somebody else to solve the problem for them, but they're not really willing to spend much money on this. Again, they're not incentivized to spend the money, but, sort of there's a little bit of a look in the mirror because, how hospitals buy drugs and from whom has a lot to do with why we have shortages.
That's very interesting. So in a system with so many vulnerable points, as you look at it overall, like how do you even go about trying to fix this, or what do you try to implement to try to correct this problem?
So let me actually back up because, I am focusing right now really on what is the major driver, which is supply manufacturing quality problems. And that has been a major problem. There are other reasons why shortages have happened. Some have happened because there was a demand increase. So, for example, there were problems accessing products that were used for patients on ventilators during COVID, right? I mean, there was a shortage of everything in COVID because there was a really massive demand increase. There were, a saline shortage. We've had two major saline shortages driven by two different hurricanes hitting two different plants for Baxter. So, natural disaster can be a driver. Um, so natural disasters can be a driver. Manufacturing quality has been a driver. Demand shocks can be a driver. So there's sort of various reasons why things can happen. How you address it really does depend on what kind of a problem it is. You can let's take natural disasters. They will happen very quickly. So thinking about how you're going to respond doesn't make as much sense. You could identify drugs without which you have no time to wait, right? That they're going to disappear really quickly. And actually, saline is the perfect example of it because the volume of it that's used is so large. Hospitals carry very little inventory of this, right? It's much easier to stockpile 6 months of carboplatin than to stockpile 6 months of saline, right? So it actually creates sort of a problem. So there's very little buffer. If there is a shock, there's very little buffer for those drugs. It's not really a manufacturing quality problem, right? So trying to prevent quality problems is not it, but, you know, diversifying supply instead of buying just from Baxter, maybe buying for Fresenius Kabi and Baxter, right? Now you have to pay more because you're not going to get as good of a deal on buying from two different manufacturers, right? So there are things that can be done to kind of minimize the potential impact and to minimize the disruption and potentially buffer it. Manufacturing quality is different in that, unlike natural disasters or a pandemic, which are what I would call an exogenous shock. It's like something that happens outside the system. Manufacturing quality is sort of a result of the system, right? So it's not so unpredictable in the sense that we could potentially change incentives and change how we purchase drugs, kind of reinforcing that manufacturers should be investing more in manufacturing quality because hospitals value it. So there is a proposal. It's not a legislative, it's just a legislative proposal. There's no bill, but Senate Finance did a series of hearings. They did a white paper and they put forward this legislative draft where they were going to basically propose an add-on payment for hospitals if they purchase and sign long-term contracts with more reliable manufacturers. So the idea was, let's change, the government has a hook through CMS, right? And so to use the Medicare program to change what hospitals value when they sign contracts with manufacturers, and shifted more towards paying attention of reliability. So that proposal is just sort of still sitting around. There's been discussion about how to revive this. The proposal they initially came up with was pretty complex. So there's been a discussion. I will say, it's difficult for Congress to act proactively. They tend to do much better in crisis. And so that window of opportunity that came up with carboplatin and cisplatin, there were just so many different hearings. And that sort of closed the way I look at it. And this is, I think, where this organization can be very helpful. We are going to have more shortages that are driven by manufacturing quality. We have had cancer shortages many times in the past. We're going to have them again. And so I think what's really important is to keep on developing proposals and getting alignment on what would address the problem, so that next time this happens, people are not scrambling to come up with a set of ideas, but there's like, oh, just pass this, right? So, we are 3 years ago when the carboplatin, or 2 years ago, carboplatin cisplatin shortage hit, we weren't there. This is really the first time that Congress started even recognizing that this was an economic problem. It really took them that long. For a long time, it was, well, let's give FDA more authority, and that somehow will solve the problem. Well, it won't, because it's an economic problem. And so, anyway, very long, convoluted answer, but we do need payment reform, actually, to make progress with this.
So as an economist, as you look at the patterns that have been happening, and because the shortages ebb and flow, like I have access now to carboplatin and cisplatin just fine. Like, how do we predict when the next shortage will happen, if it will happen, which drugs to focus on? Really hard for me to wrap my mind around that as a clinician.
So, a lot of people talk about, we need more transparency, and we need to know, we want an early warning system for drug shortages. And in a sense, that's what Congress did in 2011 with by giving FDA, or requiring manufacturers to notify the FDA that they're having a problem. The idea there, which worked, is that if FDA has more lead time, they can work with that manufacturer and other manufacturers to expand production before a shortage really hits. That kind of transparency is absolutely critical. But I will tell you, what you are asking for is a very, very bad idea. And I have told policymakers, stay away from these proposals. And here's why. When a hospital says, I want an early warning system, that means they don't want to sign their GPO contract and pay more. They don't want to do it in advance to reinforce that they're buying from a reliable manufacturer. Instead, they want to buy the cheapest, and then they want to just, they want to have a signal right before the shortage hit, so they can rush out the door, run to the bank, and just basically withdraw all the money. That actually is a very bad policy idea, and it only makes things worse. It only gives FDA much less time to deal with this. And also, this, your organization is concerned about equity. Well, it has huge equity consequences, because the hospitals that are really, a small rural hospital is not going to have a buyer. A large health system will have a buyer. There are people that are using, subscribing to all sorts of services and doing all sorts of analytics. They're the ones who are trying to get at that early warning system. So when, carboplatin and cisplatin shortage happened, you know what happened? The smaller providers were like, what the heck just happened? We don't know what happened. In the meantime, and I've seen the data, some large health systems went from sitting on 3 weeks of these drugs to a 6 month supply that they weren't going to share with anybody. And, they were securing it for their patients, but there were a lot of other patients that couldn't, right? There was the same number. I mean, think about COVID and toilet paper. There was actually not, we weren't going to the bathroom more, okay? We were not going to the bathroom more. It's just that you could no longer feel comfortable with just 3 rolls of toilet paper at home. You had to have 20. And when that happens, there's not enough supply for everybody to go around, and everybody else panics. Hospitals call this kind of purchasing behavior, because there's a signal of a potential shortage, they called it protective buying. I probably would much more call it hoarding, because that's really what it is. But we can beg to differ. But so here, sort of, this is for me, this is one of the examples of where transparency can actually really backfire. You always have to ask who needs what information and what are they going to do with it. And unfortunately, here, this is counterproductive. This is not how we get at this problem. This is how we make the problem worse.
I guess let's would like to ask you because I've been doing a lot of reading with things you have published, and I would like to have you dig a little bit more about the role of China in drug supply chains and tell our audience a little bit about that.
So, yeah, we've been hearing a lot about China and how they, and concerns that they might potentially weaponize drug supply chains. And the answer is, let's onshore. If we de-risk our supply chains from China, all of our shortage problems will disappear. And this really mixes up quite a few things and could lead to really bad policy outcomes. Number one, the shortages that we have had historically have nothing to do with China. The majority of shortages that we have had are in finished dosage forms, sterile injectable facilities, the largest fraction of which are in the United States. So it's actually US-based facilities that have been having problems. Yes, Intas is an Indian manufacturer, and so that is an example of a case where it happened outside of the US. But there have been shortages driven by facilities that are owned by Pfizer, so Hospira, by Teva, and also Acorn, a manufacturer, shut down, and that also led to some shortages because they were the only ones making certain drugs. So that's number one, is that China has nothing to do with the existing shortages. But China is a potential future threat and a future driver of shortages, and potentially very different shortages. Because when you look at how drugs are made, most of the drugs, unless they are biologic, and those are pretty much all branded drugs, the small molecule drugs, which every generic is basically a small molecule drug, are chemically synthesized. So, another sort of mistake that people say, yes, it is true that most of the active ingredients for pharmaceuticals are not made in the United States. And then, so then it's like, well, let's make active pharmaceutical ingredients in the United States. That is an important step in manufacturing of drugs, but it will not de-risk us from China if you build a facility that makes API from ingredients that are made in China. So China really controls the inputs and not as much the step of making API, and definitely not the step of finishing the product. And a lot of the discussion of onshoring pharmaceutical production is onshoring the stages that actually where China is not a big player. So there's a big disconnect, not only with what problem will it solve, but whether onshoring even would of manufacturing would actually solve the actual China problem. So there's a lot of misunderstanding on this topic, unfortunately. And on that front, what I've been telling uh, members of Congress and flagging to the administration is that there are certain drugs that we should onshore, and it's not just because of China, but because there are certain drugs for that are really essential and for which we're going to compete if there are scarce resources. I mean, think again back to COVID, where everybody wanted the same things, and in a sense, it's actually quite predictable which things we're all going to want, right? Or if there's a major supply disruption of some sort, there are certain drugs that we really will be fighting for versus other ones. Maybe we can have some substitutes if you give big enough price and so on. Those drugs does make sense to onshore. And by the way, a lot of them are, the final dosage form is already made in the US. So it's about figuring out how you, for example, make IV antibiotics. How do you actually make the active ingredient for antibiotics? Antibiotics are a big area where we really should be thinking about how to move away from China, because they actually are the ones that do the early steps of fermentation before then it's used to make the drugs. But where it makes no sense for us to onshore just because it's so much money that's at stake is thinking about, for example, statins, right? There's something like 90 million Americans taking statins. Do you know how much it would cost for us to not only onshore it, but we have to move the entire supply chain, because it's not like we're going to make the API, and the chemicals here and then ship them back to India. No, we'll have to move all of this here. So that's those are some, we have not, Congress has given basically nothing so far to in terms of money to support this. And what I've been recommending is the way we deal with those kinds of drugs is to really work with India and encourage them through sticks and carrots to try to de-risk their supply chains from China, and in that way securing our supply chains more. So I sort of have been proposing a dual strategy. Yes, onshoring makes sense for certain drugs, but be realistic. You can't onshore everything. You don't have the money. How do you deal with other drugs? You can still de-risk from China by really leveraging the relationship with India.
So, speaking of Congress, what has Congress done so far to address the drug shortages?
Not much. Lots of hearings, lots of hearings. Uh, I would say the piece of the proposal that I've already discussed, which is Senate aging, is the one that I've been most excited about. This is the first true recognition that this is an economic problem and that we need to address it by changing the incentives in the system. But other than that, there are a lot of bills that are, prevent drug shortages bill and so on, and with really, really big names. But they actually don't do all that much. It's a lot of band-aids that we've been putting forward, a lot of calls for transparency. Again, transparency can be helpful. We do need to understand where we have China exposure. But, we also know that antibiotics have a major problem. We also know that doesn't matter whether it's China or not, essential medicines are something that we really need to be thinking about. So, it's not that we need to map out everything before we know where to act. So, the sort of the really important pieces haven't really moved. Instead, there's been a lot of discussion and a lot of sound good ideas that actually aren't necessarily very are not going to take us very far. Um, so, I will say I do think that there's going to be opportunities in the next year. I mean, one good thing is that the president's budget actually does have money in its request to Congress for industrial base expansion. Um, we haven't seen this in a very long time. It's not a lot of money, but that's a positive sign. Again, Senate Finance needs to be dusted off. Um, and there seems to be interest on the Hill with respect to some of the other proposals that I have put out over the last year. For example, how do we deal with manufacturing quality issues for drugs coming from China and India? I have just because we want to leverage India doesn't mean that we should be okay with FDA's inability to inspect drugs coming from there. So I don't think it needs to be one or, that you don't have to compromise on quality. And so um, I have a proposal out about how we could change those incentives around manufacturers investing more in quality assurance. So it seems like there might be opportunities. So again, it's all about lining up proposals and getting behind them and moving things forward. On that front, I will mention there is another part of the Senate Finance proposal that I think is really critical, but has gotten major pushback from hospitals, and I want to explain this. So, the idea with the Senate finance proposal is that we want to, we can only work with hospitals. CMS can only pay hospitals. But the idea is to make sure that manufacturers that are reliable are rewarded. But what does a reward mean? Is that they actually get paid more, right? And also reliability costs money. So you have to be able to invest more in the systems. So as I frequently said, there is no free lunch here. We will have to be paying more. But the idea is not that just the hospital gets paid more, is that the manufacturer gets paid more, right? So there needs to be some level of pass through for the system to work. Because if you pay hospitals more, but manufacturers are not changing their behavior, then you really didn't change anything. You just wasted a lot of money. And so the Senate finance proposal has another element, which is to eliminate Medicaid inflation rebates for the drugs that participate in that program. And that caused huge backlash from 340B hospitals because Medicaid inflation rebates are used to calculate 340B discounts. So 340B, this hospital said, no, no, no. But if you think about this, if there is no pass through, this is not going to work. And if you look at where the 340B discounts come from, they don't come from generic drugs. They come from branded drugs, right? So if we were to reform this, going through Medicaid inflation rebates is the more palatable way because nobody is opening up the 340B program, right? So in a sense, you would think that, okay, hospitals have to give up something. It's not as much money. Nobody is messing with the 340B system in the first place. Yet there was really big pushback from hospitals going back to right incentives. This should be a no-brainer in terms of how much hospitals should be willing to sort of this seems to be a small price to pay given uh, just how small the discounts coming from generic sterile injectables are relative to the overall 340B program.
Right. I'm learning quite a lot today, and our audience has a lot of questions. So I'm going to start picking a couple of those. One question is, there has been a talk of providing more funding to ASPR, the Admin for Strategic Preparedness and Response, to advance their permanent industrial-based management to increase essential medicines. Would that work? Is that a reasonable solution?
So, yes, I actually did mention that it's in the president's proposal, I think 300 and some $1 million for industrial base. Um, I would say it's a necessary but not a sufficient condition for this to work. And I'll tell you why. You know, we will build it, they will come, just does not work here. And what you saw during COVID is that Asper actually built PPE facilities, nitrile gloves facilities, and then they could find no business. So Asper can be working on the supply side and making sure there is a facility. But if hospitals don't want to pay a little bit more from a more secure supply, they're not going, they're just going to sit idle. So there needs to be, payment reform coming with that together. And so the Asper piece alone is not going to do it. I'll flag one more thing that I it concerns me a little bit, not at all in the same way as the lack of payment reform, but Asper is pandemic and CBRN threats, so chemical, radiological, right, sort of bioterrorism type threats. That is their mission. And what I would like to see is having us think about without which drugs will the society not function well and not prepare for just pandemics and CBRN threats, right? And so their objective function or their sort of set of objectives is not exactly, I think, what I would pick in terms of how do you think about which drugs to invest in, because they might not be exactly the same ones that you would need for these kinds of pandemics are important, but they're not actually the primary reason why we've been having shortages, right? And so I do think that requires adjustment. It's a much smaller thing, but since we're talking about Asper, that's something to flag. But the lack of payment reform that accompanies it is really sort of critical. Another piece is how would they think about which part of the supply chain to invest in, right? Again, let's make drugs in the US. That means API and finished dosage form. That's not the parts that are going to make our supply chains most secure from a China perspective, right? So, to what extent, just because they have money, I want them to spend it in a smart way. So that goes back to their mission, but also it goes back to, do they fully understand what the vulnerabilities are and what's going to give us the highest return on investment from the taxpayer dollar perspective?
And then you had talked earlier about drug quality, and one of our audience members is wondering, can you describe the number or percent of foreign pharmaceutical component or pharmaceutical drug manufacturers that are actually inspected for quality? Are we tracking those metrics? Do we have control over this?
So you would need to look at the FDA website. I don't know what the numbers are. I do know that US facilities are inspected more frequently, but not. I think what's important is not that they just get inspected more frequently, but the inspections are unannounced. So, if you know that an inspection is announcing, you're going to try to tidy up the place, right? And that makes it harder. So I don't actually know the comparisons. I'm
And I
sure
know
that FDA has these statistics.
And I know you talked a lot about, the concern for hospitals potentially stockpiling drugs, but one of our members is wondering, well, as with health insurance companies who require to keep funds in reserve, why shouldn't we propose that hospitals always have certain basic and critical meds in reserve at all times as well?
Yes, so that I would agree with if it's not done when there's a signal of a shortage, right? So having a buffer does make sense. CMS had a proposal like this in place. They were sort of considering this kind of proposal during the Biden administration. There there are a couple of concerns, and I think they backed off from this a little bit. One is, how do you stand this up without causing shortages, right? If everybody does this and sits on 6 months supply, we're going to have a bit of a problem. So that was sort of one concern about how do you really sort of stand that up. And and then also, how do we pay for this? I mean, hospitals could be doing this now. They want to be paid for this. And so, again, this goes back to, where does the money come from? What ultimately CMS ended up doing is setting up a program where independent rural hospitals would get an add on payment for basically getting a 6 month supply of these critical medicines, because again, remember, they're the last ones in line usually when there is a potential shortage, because all the health systems buy out everything. So the idea was to sort of help those that tend to be left behind. The problem is that CMS's ability, it's the same problem that they had with domestic N95 masks, is the tool that they were using is economically not a very attractive tool. You don't get paid for the full difference of what you paid for, basically. And so, the N95 mask rule was not very successful because hospitals just didn't want to be sort of subsidizing the program. Again, goes back to what extent are hospitals internalizing? Here, the government is helping to close the gap, but the hospital is just saying, no, 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 you have to pay me everything and the full difference. So anyway, I don't know what the uptake has been, but I would not have been surprised if the smaller hospitals wouldn't have that. Now, there are not a government sponsored solutions, but there are solutions like this. There are programs from wholesalers where you can sign up for a certain level of inventory that the wholesaler will hold for you. GPOs, they also have this. Civica, perfect example. You sign a long-term contract with them for certain drugs, and you have to commit that you'll buy a certain share of drugs from them, but they will hold 6 months supply. Instead of the hospital holding it, they will hold a 6 month supply in reserve for you. And if there is some sort of a shock. So the options exist. Uptake is not as good as one would hope.
All right. And I guess the last thing I would ask you, Martha, is like, as you can tell from the questions I've asked you earlier, as physicians, we may not really have a good understanding of the economic aspects of this. How can we, as clinicians, best advocate for change, reform, and really be part of the solution rather than create additional problems?
Yeah. So I would say, I mean, I think it depends, what role you play in the ecosystem. I think for anyone who is actually engaging with policymakers, it's and especially for anyone who is sort of new to this space, I would say it's so important not to jump to solutions that sound good. There's so many solutions that sound good but just won't make a difference, and I feel every conference I go to, I feel like somebody has this great idea, and I just it's because folks don't necessarily understand the ecosystem and the main drivers of it. So I think, if you are engaging with policymakers, it's really important that you really sort of understand what the issues are and really understand the economic issues. That's really key. If you are sort of behind the scenes, I do think that there's a lot of work to be done with your hospitals, with the hospitals that, questioning them as, do you have a long-term contract? Are you signing up for these different programs? How do you vet, the reliability of these manufacturers? What's your stance if you're a 340B hospital? What's your stance on this idea that we do need to have pass through for and in or basically pushing back on this idea, don't ever touch Medicaid inflation rebates. So I think for pretty much everyone in your group, there's a lot of questions to be asking of hospitals, and for those who are much more sort of hill facing, policymaker facing, is just being really keenly aware of the broader kind of incentive misalignment, and just really not jumping to what's sound good ideas.
Thank you so, so very much. I really want to close this session by thanking you for such a thoughtful and it's a discussion that really left me with a lot of things to mull over, and just an interest in learning more and educating myself more. We're so grateful that you were able to join us, that you were patient with all of our questions.
Well,
Uh,
and I thank you for being patient with my computer restart. That was yeah, that was not
but what is
not
a
a
webinar without some technical
I
difficulty?
know, with some
No
technical
problem.
difficulty. If I could just say, unfortunately, because I'm on the phone, I can't drop in a link to a website where I have all my papers. But for readers, there is a paper that I wrote. I mean, if you go on my website, you'll see there's many, many papers. But if there's one paper to read, there is a paper that I published, I think might have been 2 years ago. Basically, it's entitled "Guide to Policy Solutions Drug for Drug Shortages," something along these lines. And if you wanted to read just one paper, I would encourage you to read that paper, because that's the one that helps you walk away from, oh, this sounds like a good idea, and it gives you a framework for how to think through the problem. And so in a sense, it kind of gives you a set of tools rather than, a bunch of solutions. So I would really recommend that paper.
Perfect. And we've put the links right in for the chat,
Excellent.
a link to your main page and to the specific papers.
Thank
And yes, I highly recommend that everyone reads this. I learned so much reading from it. So thank you so much.
thank you.
And finally, I just want to thank our audience for spending this hour with us and for everything you do every day on behalf of your patients. If you aren't already, we hope that joining us tonight will encourage you to join us as a DFA member so that you connect with other like-minded people sharing the same values and priorities. Please keep an eye out for additional opportunities to engage with DFA, including our National Leadership Conference, which will be held in Washington, D.C. on June 6th to 9th. And please see the registration link in the chat, get your ticket, and hope to see you this summer. And for those of you that are already sustaining members of DFA, this is just a reminder to complete the survey that we will put in the chat so you can claim your CME for tonight's session. And if you enjoyed this session half as much as I did, please consider supporting DFA's work and impact with a financial gift. The link to donate will also be put into the chat and is available on our website. And finally, just remember to follow us on our social media handles. We're pretty much on all of them. And we thank you so much for attending and hope everyone has a great rest of their evening.